Hi, I'm Mike DeArmond. I'm a physical therapist, and I put this video together to show you how to do adverse nerve tension testing of the upper extremity. This is intended for any physical therapist, occupational therapist, or any other practitioner who might deal with upper extremity pain, whether it be a PCP, neurologist, rheumatologist, orthopedist, what have you. It's an important skill, I think, in diagnosing pain in the upper quarter, and I find it a very valuable tool, mainly because I sometimes see in clinic patients with elbow pain or shoulder pain or wrist pain that don't typically follow the normal pattern of, say, shoulder impingement or lateral epicondylitis or medial epicondylitis or carpal tunnel syndrome. And when they don't follow common patterns, when the tests don't really play out, it's sometimes, I think, important to kind of dig a little deeper, and sometimes looking for a neural component is possibly the answer. The testing is relatively simple and easy. It can be done very quickly and efficiently when you know how and you have some practice, and that's what I really want to be able to try to give you guys, give you today. My aim is to not necessarily be completely comprehensive, but at least give you some good clinical tools that you can use, give you some foundation for why these tools are good, and give you some confidence in the ability to use them in clinic. So the idea of adverse nerve tension as a pain generator is not a new concept. From the beginning of medical history, the idea that tension on nerves or the irritability of nerves could cause pain is not an uncommon theme. We in physical therapy have certainly learned about the straight leg raise test, popularized predominantly by Syriacs in the 30s and 40s. But of course there have been documented cases or documented use of nerve tensioning even prior to that. Certainly from the Phelan, Tinel, these physicians have all studied adverse nerve tensioning and how it can manifest into pain. Maitland in the 70s came up with a slump test, which was a kind of a more nuanced way to test nerve tension in the lower extremity. Most recently, David Butler is probably best known for his study of adverse nerve tension and how the biomechanics of the nervous system can relate to pain. He published The Mobilization of the Nervous System in 1991 and The Sensitive Nervous System in 2000. These have become essential texts for anyone who is studying how nerve irritability can be a pain generator in the extremities. So, some key concepts include thinking of the entire nervous system as one continuous unit. As peripheral nerves branch off further and further out as they get further from the central nervous system, they're like branches of a tree. Although subdivided greatly, they're still ultimately connected to its trunk, to its roots. That nerves are essentially long, physiologic, wet tubes that can transmit irritability anywhere along its length. This also comes into play when we talk about the quote-unquote double crush syndrome, where, well, for instance, I can touch my ulnar nerve quite easily. That doesn't hurt. Nerves are actually pretty tough. They can deal with contact. If a disc bulges against them, they're not necessarily going to send pain signals. But if that happens chronically in one spot, it may increase irritability of the nerve. If multiple sites along the path of a nerve are compromised, they can have a summative effect, eventually driving the nerve past a certain threshold where pain is actually perceived. So these points of compromise kind of fall into some classes in general. They can be areas where the nerve branches, where the nerve may abut soft tissue or osseo or fibro-osseous tunnels, like the posterior interosseous nerve, the arcade Frosch, for instance, in the upper extremity, where the system is relatively fixed. The common perineal nerve at the fibular head is a good example. Any place that may be relatively superficial or exposed to friction. The lateral humerus for the radial nerve is a site that can be compromised. And also any tension points along the spinal cord itself. There are some natural tension points at C6, T6, and L4 that can actually kind of impinge on nerve roots. So upper extremity nerve tension testing is not dissimilar from lower extremity nerve tension testing, most notably the slump or straight leg raise test. Essentially, we're putting the upper quarter in a position that maximally or that tends to tension the median, ulnar, or radial nerves specifically. And by doing so, we can determine if there's a neural component. Now, what defines a positive test? We generally look for, one, a reproduction of the patient's symptoms. For instance, I personally can get into any of the upper nerve tension test positions and have an increase in pain, but I don't have pain at rest. So I'm not technically a positive test. I just happen to have a little increased irritability. Is there a difference from side to side? Again, kind of going back to the idea that the patient may just have a baseline irritability or a position sensitivity that isn't necessarily related to their symptoms. Most importantly is, does the pain change with a change in position of a remote component? So, for instance, and we'll go over this a little bit more in a second, if I get the patient in a median nerve position and they have pain at their wrist, and I change my wrist position, the pain goes away, that proves nothing. The pain in my wrist could have been musculotendinous or it could have been nerve. By relieving that wrist component, I have changed both and I've muddied the picture. If I get into that median nerve position and I have wrist pain and I move my head and the pain changes, there's only one reason why that wrist pain could be different, and that's because of a change in neural tension. So it's very important to keep that in mind. Now, one of the most sensitizing maneuver of all of these is the depression of the shoulder, and that's going to be a common thing with all of these tests. So depression of the shoulder is a key component of all four of the tests that I'm going to show you. Depressing the shoulder approximates the clavicle and the first rib and biases the brachial plexus tremendously and has a huge effect on how the tests are interpreted. So let's talk about the tests. There are two for the median nerve. Median nerve probably gets a little bit more attention because I think it is considered to be kind of the barometer for all nerve tension. If the median nerve is positive, the chances are radial and ulnar will be 2. Also, of course, the implications of carpal tunnel syndrome makes the median nerve kind of a usual suspect that likes to get investigated a lot. So the position for provocation of the median nerve is shoulder depression, as we mentioned before, shoulder abduction to 100 degrees, shoulder external rotation, elbow extension, wrist supination and extension of the fingers. So as I wind up, you'll see that I use my nearer leg to kind of maintain that abduction of the shoulder, and I get that shoulder depressed. Hold that, and that's so key because, again, one of the most sensitizing maneuvers because of the approximation that it causes between the clavicle and the first rib. Really sensitizes the brachial plexus. So maintaining that, the next most critical aspect is maintaining good hand position. And you'll see that pistol grip that helps maintain extension of all the fingers in the thumb and the wrist at the same time in a nice, controlled manner. As I move the patient into the test position, at each stage continuously I ask the patient if they're having any changes in their symptoms. At any point when their symptoms are reproduced, I stop. It's critical to determine at this point where their pain is. As we described before, the median nerve position tensions the nerve along its length. The pain can be distal, like in the wrist or the elbow, or more proximal. If it's distal pain, one of the great maneuvers you can do, one of the things you can relieve, is to simply allow elevation of the shoulder. This is my preferred way of determining a test of distal pain, seen here. Another option, if they have distal pain, is to allow for movement of the head. This also relieves nerve tension. The problem is a lot of patients want to roll, like my subject here is doing. What I will do very often is demonstrate exactly what I want the patient to do, and then have them demonstrate it independently before the test begins, so there's no confusion once we begin the actual test. So if we have pain and it's distal, and I want to move a proximal segment, side bending the head is a good option. Helped a lot with this patient. Another option is to have the patient side bend away from the symptomatic upper extremity. This may cause an increase in symptoms, thereby further corroborating your hypothesis. Now, if the patient's symptoms are proximal, you can't rely on the altering of a proximal segment for your test. You'll have to rely on a distal segment, like the hand. Releasing the wrist tension usually suffices. So let's look at this one more time. So begin with getting hand position set first, getting that shoulder depression and that abduction, maintaining it with good body position. Now, the sequence of events here is less critical than your consistency. Practice this if you're going to use it, and make sure you do it right the same way every time. So good wrist, finger, thumb extension, not letting that abduction or that depression slip. So you move carefully into external rotation and elbow extension, asking the patient constantly if there's a reproduction or a change in their symptoms. And when there is, I stop. If I find pain, and in this case distal pain, and in this case I relieve the shoulder tension, and my patient has relief. Positive test. What if the patient has a lot of shoulder pain? As we've seen with upper limb tension test 1, it starts with a lot of abduction and external rotation of the shoulder, which can be quite painful and provocative, and that's why we might want to use upper limb tension test 2, also for the median nerve, but it's a little bit different. This is where we use upper limb adduction closer to the body, the same hand and wrist positions and elbow extension, depression and external rotation of the shoulder, but it begins in adduction, which is much less provocative. So the test begins with the same positioning of the hand, that same pistol grip that I showed you with upper limb tension test 1, identical, wind up, making sure all those fingers in that thumb and the wrist stay extended. And we keep that elbow extension. This here I'm using my knee, my thigh to kind of keep that elbow extended as I work her up into abduction to the point where my patient has symptoms. Again, if the patient's symptoms are distal, I can elevate the shoulder, or I can use head positioning to kind of tease out if head positioning can relieve or exacerbate the symptoms. Of course, if the symptoms are proximal, releasing the hand is the way to go. Next we have upper limb tension test 3, which is actually for the ulnar nerve. Positioning there is for wrist and finger extension, but pronation now, not supination like in test 1 and 2. Now the difference is elbow flexion instead of extension. Shoulder external rotation, abduction, and of course depression remain critical to this test. So we can watch the wind up here, again using my leg to assure that we keep abduction and shoulder depression. Now look at my hand. A little different handhold for this. We want to try to keep all those fingers extended, but along with the wrist being extended as well. So then again, working into external rotation, pronation now, and ultimately tensioning with elbow flexion. I can release the shoulder to see if I can change distal symptoms, or again the same head protocol here to possibly relieve, or side bending away to possibly provoke further symptoms. Again, if there's proximal symptoms, simply releasing the hand will help indicate if it's nerve tension or not. Finally, we have upper limb tension test 4, which is for the radial nerve. This position, a little different again. Final test position is wrist and finger flexion, pronation, elbow extension, and shoulder internal rotation. Again, abduction and depression are critical. So here's the wind up for this one now. Hand position is a little different. Now watch how I keep her shoulder depressed using my hip instead of my hand. This is so I can use both hands to control a little bit better. Another little difference is I'm facing the patient's feet in this one, unlike every other test where I was actually facing the patient's, facing the patient. So again, this handhold I want to go over a little bit more too. I like to use get all the fingers and wrists into flexion, but I like to leave the thumb out. You'll see some in some writings where the thumb is included, but this kind of causes kind of a Finkelstein's effect in some folks, which can be very painful. It's not really telling me much about the nerve, but it does tell me a lot about some possible symptoms the patient may have with their thumb extensor tendons. So I prefer, again, leave that thumb out of it and just use the fingers. So as the test position continues here, watch that one more time. I'll use my other hand to kind of help maintain that extension, and I work into abduction until the patient has symptoms. Again, I can release the shoulder, or we can work with the head side bend protocol to see if we get a relief or change in distal symptoms. And as with all of them, if the symptoms are proximal, releasing the hand may cause relief, and thereby implicating the nervous system. Okay, well that's upper limb neurodynamic testing 101. I hope you found it useful and helpful. I hope it helps add another tool to your toolbox when you see that patient with some upper extremity pain that doesn't quite look like what you expect it to look like, that carpal tunnel syndrome that doesn't quite have the right symptoms. I've seen carpal tunnel before where I've ended up finding adverse nerve tension and neck pain, manipulated a cervical spine, retrained or trained postural musculature, proximal musculature, and made wrist pain go away. It's a lot of fun when you can find it and treat it that way. There are other treatments, of course. There's a lot out in the literature about the value of nerve tensioning exercises or sliding exercises, sometimes called nerve flossing. Neuromobilization is also a term that's used out there, and these are good ways to address adverse nerve tension when you find it. Again, there's a lot more out there. There's a lot more to learn, but I think I've kind of given you some basics that you could definitely use in practice starting tomorrow. Again, thank you very much for your time.